Kia ora, ko Susan Lane toku ingoa. I am a psychiatrist working at CADS, and I work in the medically managed withdrawal unit, which is our inpatient detox unit currently based at the Auckland City Mission home ground building on Hobson Street, so that new flash building in the centre of town. In thinking about what to talk to today, medication-assisted alcohol withdrawal is my topic. Huge topic. I'm going to go over this fairly quickly, but I'm going to try and highlight a few helpful resources so if you want to dive a little bit deeper into this topic. Hopefully this is going to be quite practical, not very academic, sorry. I decided to do a who, what, where, when, why, how, but I'm not going to be beholden to doing it in that particular order. So I thought I'd start with why. This is hot off the press. This is Rose Crossan and colleagues who have published in June of this year a study which was assembling together a whole bunch of experts in AOD issues and getting them to rank 23 different psychoactive substances, looking at a whole lot of parameters of harm to self and harm to others. Spoiler alert, number one, alcohol. 2021-2022 New Zealand Health Survey, about 19% of adults in the general population were drinking in a hazardous fashion. Goes up to about 33% when we look at New Zealand Māori. So of those people who are drinking in a hazardous way, a significant minority will be drinking dependently. Why do we care about alcohol dependence and withdrawal? Now, bear with me, this is an analogy I find helpful. I like to think about the brain as being a little bit like a car. If you constantly expose the brain to the potent CNS depressant that is alcohol, it's a little bit like trying to drive with the handbrake on. You've got these slow down messages to the car, but if you want to try and keep your car travelling at a reasonable speed, you can slam your foot to the floor on the accelerator. And the brain does something a little bit like this when people are drinking dependently. There is underneath all that alcohol a latent hyperexcited state of the brain. What happens though when the handbrake drops, when you suddenly stop drinking, the car careens and out of control and can potentially crash. And this is what we experience when people go into alcohol withdrawal. That latent hyperexcited state of the brain becomes overt. And so what we can see is people get shaky, sweaty, tachycardic, hypertensive, but the potential crash is that people might have seizures or delirium tremens, potentially life-threatening complications. And again, why medicated alcohol withdrawal? Because nobody needs to die of alcohol withdrawal in this day and age. I like to think about benzos, which we have had available to us for the treatment of alcohol withdrawal for about 50 years or more, as being a little bit like putting your foot on the foot brake to try and slow the car down and then slowly releasing it over the next week or so that the car can slow down and not be at risk of crashing, so the brain can get back to a more of an equilibrium again without being at risk of those kinds of complications. Who do we offer a medicated alcohol withdrawal to? This slide is really just to emphasise that not everybody needs medication to stop drinking safely. I know that in primary care you are over-encumbered with screening tools and instruments. The Audit C is a reasonably straightforward one. 3 questions. How often do you have a drink containing alcohol in the past year? How many drinks did you have on a typical day that you were drinking? And how often did you have 6 or more drinks on any one occasion? From that you get a score. If you have a score of 10 or less, you are unlikely to require medication support to withdraw. A score of 11 or 12 says likely alcohol dependent. We need to drill down into this a little bit more. Now, of course, we don't offer an alcohol withdrawal, medicated alcohol withdrawal, to someone who doesn't have a goal to stop drinking. Now, this is where I'm going to point you to where you can find most of the resources. So if you look at Auckland Regional Health Pathways, if you look at mental health and addictions, then you look at addictions, alcohol screening and intervention. Sorry, this is a bit painful. But then you find this wonder trove on the right there at the key links area. That's where you can find all of the resources I'm going to talk about today. So at the very top in that key links section is something called the Community Alcohol Withdrawal Flow Chart. So if we're thinking about the health settings where people can have a medicated alcohol withdrawal, in some circumstances it's really appropriate for people to have a medicated alcohol withdrawal in primary care. But how do we figure that out? Well, this is a bit blurry, sorry, but this is what you'll find if you go under this quick link. It's a nice sort of decisional algorithm to help you figure out whether or not you should be offering medicated alcohol withdrawal to someone in primary care. So you can see it along the top. If they're sick, they should go to hospital. The next line down, do your audit C. You get a score of 11 or 12. We need to ask some more questions around the pattern of people's alcohol use, what their past detox experiences have been like, what are their mental and physical health comorbidities. The algorithm goes down like this and gives you some indicators about the kind of people I wouldn't be touching in primary care in terms of medication support. So people who are drinking over more than 20 standard drinks of alcohol per day. Remember to calculate the standard drinks. You need to know the volume of the alcoholic beverage they're drinking and the percentage of alcohol. Then you can go on something like cheers.org.nz and plug in the numbers and figure it out. A lot of people will drink doubles. Then you can go down there and you can see that people who are drinking a lot, people who have got serious physical or mental health comorbidities, people who have had previous complicated withdrawal reactions, I wouldn't be advocating for detoxing them in primary care. We'll talk a little bit more about medications otherwise, but obviously these are other considerations to think about in primary care. Firstly, as a busy practitioner, do you have the capacity to monitor and follow up that person while they're going through their detox? And what is the person's home situation like? Do they have a safe, sober caregiver who's at home with them, who could call you and let you know if it's not going well, who could take them to hospital if they're getting sick? Secondly, I'd strongly advocate for not giving people their whole lot of detox medications all in one go. What we would usually do is get people to pick up their medications daily from the pharmacy. If the person starts drinking again, stop their script. It's really dangerous to combine benzodiazepines and alcohol generally. There's some rare exceptions. Let's not go into that. Anyway. And also, I'd be very wary about providing repeated detoxes for people. We know that detoxes are potentially harmful for the brain, particularly if they are not followed by a sustained period of abstinence after them. It really suggests we need to go back to the drawing board and think about what support that person needs to stay stopped after a detox. Might be a good opportunity for a referral to CADS. If you don't know, we've got a GP advice line. You can call us Monday to Friday during working hours. After hours, you could be put through to our on-call doctor. Where else can you get a detox? Well, you can go to CADS. Now, you can refer to us electronically in the same way you'd refer to any specialist service. Please include enough information about people's drinking so we know what part of the service they're best served to go to and what their goals are. Please ensure that you've got contact information for the client on the referral and that they've given their permission for the referral. Oh, a note on social detox. Many of you probably don't know about social detox. Social detox is the next level up in the Mission Homeground building from where our detox unit is located. It's run by Auckland City Mission staff. If the main barrier to someone having a home detox is their home environment, that they don't have good support around them, this is potentially a place where people could go and be supported with a bit of medication to come off alcohol as well. But where I work is the medically managed withdrawal unit. So we are one of 3 specialist detox units around the country, 10 beds. People usually come in for about a week. And we've got kind of a fairly comprehensive multidisciplinary team to support people through their detox and with their aftercare planning. The other place you can get a detox, potentially you can get admitted to hospital and have a detox. My experience has been hospitals are very reluctant to admit people for a detox if that's the only reason someone is presenting. But if someone's broken their leg or they've got a chest infection, they may need to be detoxed when they're in hospital. Important consideration about this is that because people go into hospital for another reason, they may not actually have a goal to stop drinking. So it's really important we think about when they're discharged from hospital, whether it's safe or not for them to continue getting benzodiazepines. And you might kind of come up against this in primary care where someone's been given a whole lot of diazepam and they're continuing to drink on top of that. This is just a little bit of a health and safety warning. There are lots of wonderful private detox providers out there and lots of GPs who have good relationships with those private detox providers. We've been getting a few messages sometimes that poor GPs ring us up on Friday afternoon and a client has been booked in with them. They've never met them before. They've been asked to provide medication support for a detox at a medical care facility that they know nothing about. I would say that's a wee bit of a red flag around prescribing because you're responsible for what happens with that prescription thereafter. In terms of how we can withdraw people from alcohol, this is really just to say that there are some people who are alcohol dependent who will be able to gradually cut down their alcohol consumption in a safe manner. Our experience is that can be quite hard to do. So if we're thinking about medication-assisted alcohol withdrawal, this slide is just to emphasise that our preferred medication tends to be diazepam, and that's because it has a short time to peak action, but it also has this really active metabolite, nordiazepam, and it has a long elimination half-life. So it tends to hang around and slowly taper out of the body, which makes for a much smoother withdrawal experience for people. Thank you. The people we need to be careful about are people who've got significant liver disease because we know that diazepam is hepatically metabolized. Also, we know that your capacity to metabolize diazepam reduces significantly. I think it's like every year over the age of 45 or something like that. So we tend to not use diazepam for people over 65 in our medically managed withdrawal unit. And you'll see that on that community withdrawal flowchart, it said maybe don't detox people over the age of 65 in primary care. This is part of the reason around this. So we use lorazepam, mostly because oxazepam is no longer available in New Zealand. In terms of specific medication-assisted withdrawal strategies, the one that you'll see on our primary care pathway is a fixed dose regime, which is fixed dose, which is about trying to kind of estimate people's medication requirements on the basis of how much they're drinking and then kind of tapering it down over 5 to 6 days. You may need to adjust this a little bit depending on how people are going. That's why there's a need for being able to regularly review and follow people up. Do a similar kind of thing in hospital as well because the staff there aren't, it's not their bread and butter to do detoxes, but they'll have a mild, moderate, severe regime. The severe regime's 80 milligrams of diazepam in the first 24 hours, and people will often also have PRN on top of that if that's not enough to cut the mustard. There's this other way of withdrawing people using diazepam. Don't tend to use very much, I think, in places around New Zealand, but you can effectively give people diazepam frequently over the first day or two until they're lightly sedated and then just stop it. It's kind of leaning into the self-tapering aspects of this medication. The way we do it in our inpatient unit is that we do a symptom-triggered withdrawal. So our nursing staff are really experienced in working out how much medication people would require to safely withdraw. It's a real luxury for me as a doctor. I prescribe diazepam 2.5 to 20 milligrams up to hourly, maximum of 160 milligrams per day, and leave the nurses to it. It's great. The nurses then figure out about how much they need in the first 24 hours, give them a similar amount in the second 24 hours, and then taper them down over the next 5 or 6 days. Don't forget thiamine, please. In our unit, we use parenteral thiamine, either Pabrinex or intramuscular thiamine, because it's not particularly well bioavailable, particularly when people have got inflamed, irritated stomachs from their regular alcohol consumption. Timing considerations. Look, ideally, you're not going to start a detox for someone at home on a Friday afternoon. It's not great. That being said, I really feel for you because often people turn up on a Friday afternoon and it's 24, 48, 72 hours past their last drink and they're shaky and sweaty and you're like, so give us a call and we're happy to talk it through with you to see what we can do to put a Band-Aid on that if needed. We know that there's a bit of a wait list for our unit. At the moment, not too bad. More like 3 weeks rather than 6 weeks. So people are going to have to wait for a bit of time before they can have a detox with us. They'll need to go to hospital if they're sick. Otherwise, they're going to need to maintenance drink. This is where we go back to that health pathways. This is where you find the information about maintenance drinking that you can read yourself and print off for your patients. The other thing is, I don't think the wait list is always a disaster, because giving someone an acute detox without a comprehensive plan around how they're going to stay stopped afterwards is a particularly good idea. We know repeated detoxes are potentially harmful for people. So using that time while you're waiting for a detox bed to be able to try and shore up a good aftercare plan is really important. So there's a number of NGO residential treatment providers where people can have inpatient treatment, or they can engage with outpatient support via places like CADS or AA. What else? I'm nearly done. I think I've come in time as well. Woo, woo. So 2 medications that just to think about in terms of things that can assist people to come off alcohol as well. So naltrexone, opioid antagonist, it can reduce cravings for alcohol. Also, if people drink while taking it, which isn't dangerous, they may have less of a pleasure response from the alcohol. We need to do the initial application form for the special authority. They're meant to be engaged in an ongoing treatment program to meet criteria. And just be cautious around people who might be opioid dependent, because you start naltrexone, you can put them into precipitated opioid withdrawal. And also we give people a little red wallet card, so if they needed emergency analgesia for any reason, that they would know that they're on naltrexone, they might have to use something different or much higher doses of opioids to get on top of the naltrexone. And then disulfiram, an oldie but a goodie. So this is also called antabuse. This is the one that people take it hoping not to get any effect from the medication, because if they drink on top of the disulfiram, it will potentially trigger this disulfiram ethanol reaction. Very unpleasant, sweaty, hot, nausea, might even end up in hospital. Don't give it to people who've got significant cardiovascular disease or anyone who you think may not be able to physically tolerate that reaction. There's this rare idiosyncratic liver reaction. You need to monitor people's liver tests throughout the whole duration of treatment. It's not good for people who've got severe liver disease or cirrhosis. The main nugget for disulfiram is we've got to the space now where we are really reluctant to prescribe it unless there's a plan for supervised consumption. The evidence is best that people have some kind of accountability around taking this every day. This is where you find the prescribing information for naltrexone and disulfiram. And this is where you find more about withdrawal management for alcohol and other substances. This is Te Pou and Mataraki guidelines. And this is where you find the link to them on health pathways. That's all I've got.